Hi, this is Dr. Sham, and we are going to discuss today about the diabetes insipidus. That is a syndrome associated with the deficiency of ADH. So ADH normally attacks on the collecting tubules and causes the water reabsorption, thus concentrating the urine. So if no ADH is produced, this means that more urine is produced. Okay, so diabetes insipidus. Now there is a difference between the diabetes insipidus and the mellitus. There are a lot of differences, by the way, but in the diabetes insipidus, a large volume urine is produced, but that is ironically insipid. But in the diabetes mellitus, the urine is sweet, because it's losing a sugar. So it's a large volume, but is containing the sugar. But in diabetes insipidus, it's just the urine. There's no sugar in there. Now there are two types of diabetes insipidus. Let's talk about the causes and the types. So there are two types, central and the nephrogenic. Now, here is the difference. The central diabetes insipidus is a disorder of neurohypophyseal system, and there is a partial or total deficiency of the ADH. ADH is also called vasopressin, which results in excessive dilute urine. Okay, but in nephrogenic diabetes insipidus, the ADH is normal, okay, or it could be high, but there is a resistance to the action of this ADH. So in the central diabetes insipidus, there is deficiency of vasopressin, either partial or total. In nephrogenic, ADH is there, ADH is here, but it is the receptors and the collecting tubules, they are resistant to ADH. So ADH is there, but it's now working on the receptors. The causes of central diabetes insipidus is head injuries, radiotherapies, neoplasias like pituitary and the hypothalamic or pituitary surgery, meningitis, syphilis, encephalitis, TB that can cause severe head injuries, anoxia can cause. So these are all the causes of central diabetes insipidus. While nephrogenic is caused by hypercalcemia, hypokalemia, pyelonephritis, and importantly, these drugs, lithium, colchicine, or demycocycline. Demycocycline. This is a tetracycline actually. So these are the causes of the nephrogenic. Other could be there like sarcoidosis or sickle cell disease, amyloidosis. But you need to remember at least these. So the causes of the types and the causes of nephrogenic diabetes insipidus. Now let's move towards the finding. So the patient is either not having the ADH like in central diabetes insipidus, or the patient is having but that's not acting on the kidney. Okay, so what will be the findings? So no ADH, so this means that they are going to produce a large volume of the urine, okay, excessive thirst, and they're gonna be dehydrated, and that can lead to like serious dehydration, okay, electrolyte disturbances as well. So let's go towards how you're gonna diagnose. So the patient is producing a large volume of the urine, so urine osmolality will be low. Okay, you have dilute urine, okay, and you have concentrated plasma. So increased serum osmolality, decreased urine osmolality, and hypernatremia, because you are losing the fluid in your urine, so your plasma is more thickened, so there will be the hyponatremia. Now let's go towards the ADH level. So ADH level in central diabetes insipidus, we know that they will be lacking, totally lacking or partially. While in nephrogenic diabetes insipidus, there is the ADH is even high, but it's resistant. Like the kidneys are resistant to that. So the ADH is high, but it's not actually acting on where it should act. So again, increase serum osmolality, decrease urine osmolality, hypernatremia, and the ADH levels. Now, next go towards one thing, that is a water deprivation test. A water deprivation test. What is that? Let's talk about the water deprivation test. This is actually to establish the diagnosis of diabetes as well as the cause. Okay, so what happens is that in the water deprivation test, I'm going to tell you that one in detail here. So what happens that in the water deprivation test, okay, if I'm going to divide this line on, okay, this is 8 hours, okay, this is 0, this is 8, and this is next 8 hours. So what happens is that a patient is deprived of any kind of the fluid for the 8 hours, okay, and after the 8 hours, okay, the urine osmolality, this is measured. So in a patient with diabetes insipidus, the urine osmolality after the fluid, what happens after the fluid deprivation in a normal person? If you are not taking any fluid for the 8 hours, the urine should be concentrated. But here, the ADH is not produced. So after the 8 hours, even after the fluid deprivation, the urine osmolality will be high. The urine osmolality will be low. Sorry, the urine osmolality, because the urine is actually that is diluted even after the water deprivation. So urine osmolality will be low. So after the 8 hours of fluid deprivation in a normal person, the urine osmolality should be high. But here the urine osmolality is low. Now here you give the desmopressin, that is the ADH analog, okay, the ADH, synthetic ADH, okay. So you give that one. So what happens that in central diabetes insipidus, the ADH was lacking. So as soon as you give the ADH and you measure the urine osmolality after 8 hours, so what happens? Now the urine osmolality is increased. But in nephrogenic diabetes insipidus, the urine osmolality will be still, that will be still low. So this is how it establishes the diagnosis as well as helps differentiating in central and diabetes insipidus. So 8 hours, I'm going to summarize again. So 8 hours of the fluid deprivation, you measure the urine osmolality in the diabetes insipidus. After fluid deprivation of the 8 hours, the urine osmolality is still low. Okay, and now you give the desmopressin and measure that. If it's still low, this means that this desmopressin that is not actually acting okay on the kidneys, so urine osmolality is still low. This means it's a nephrogenic diabetes insipidus. But if it goes high, okay, this means that it is central diabetes insipidus. Let's move toward the management. um, so in the central diabetes insipidus, definitely you need to give the desmopressin, okay, because that it's a partial or total lack of the desmopressin. Okay, so you need to give the desmopressin subcutaneously, orally, or intranasally. Um, yeah, and in the nephrogenic diabetes insipidus, there is already the desmopressin. You need not to give the vasopressin, okay, because it's there, but it's not acting on the kidney. So you give the diuretics, actually, amiloride, may be used, which enhances actually the reabsorption of fluid from the proximal tubules. You can use chlorthalidone, it's also effective. So that's about the diabetes insipidus.